On behalf of the Patient Safety Authority, I would like to welcome you to this webinar titled Treatment Innovations for the Behavioral Health Emergency Room Patient. My name is Kelly Gibson, and I will be your moderator for this program. Now I'd like to introduce our speakers for the webinar. Dr. Dale Brickley is currently the Senior Director of Operations for WellSpan Philhaven, in addition to overseeing operations for a freestanding psychiatric hospital. Dr. Brickley is also responsible for the clinical and operational functioning of embedded behavioral health staff in system emergency rooms and community crisis intervention programs. Adam Miller is a licensed professional counselor serving as the Director of Access and Crisis Intervention Programs at WellSpan Philhaven. He has 15 years of experience in the mental health field, both in leadership and as a clinician. Billy Fisher is a licensed professional counselor serving as the Operations Manager of Behavioral Health Coordination at WellSpan Philhaven. He has experience working in various capacities over the last 11 years, ranging from inpatient and crisis intervention to outpatient services. His responsibilities include direct oversight of behavioral health services within the system emergency departments. Dr. Nidhi Garg is a child and adolescent psychiatrist at WellSpan Philhaven. She completed her residency at Einstein Medical Center, Philadelphia, and did her fellowship at Penn State Medical Center. Dale, I will turn the program over to you.
Morning, everybody. Thank you for giving us an hour this morning to discuss an issue which is near and dear to our hearts, and I'm sure near and dear to many of your hearts as well. We're going to talk about some treatment innovations for the behavioral health emergency room patient, with our goal being trying to identify interventions and techniques to help make that experience safer for the patient, safer for the staff member, and a better overall treatment experience for all involved. WellSpan Health is a acute care health system in South Central Pennsylvania. We have 8 hospitals, and we serve individuals in the York, Adams, Franklin, Lebanon, and Lancaster markets. We have 6 emergency rooms. We have 4 behavioral health hospitals. One of those is freestanding at Philhaven Mount Gretna. 3 of those are embedded behavioral health units within acute care health systems. We have brought together an interdisciplinary team to help address the rising number of behavioral health patients we're seeing in those emergency rooms and working to improve safety for all. Our objectives are we're going to discuss the current state of the work related to the behavioral health patient within the emergency room. We're going to describe the limitations of the emergency room as they currently relate to behavioral health patients and their treatment. And we're going to describe the future state of utilization of crisis intervention, as well as some embedded emergency room programming to help impact safety. What we know is that in Pennsylvania, over the course of the last several decades, there has been a push to treat patients in the community, to provide the right level of care in the right location, utilizing the least restrictive interventions in order to help people receive the help that they need in a manner that is not stigmatizing and safe at the same time. These community resources tend to be set up for mild to moderate severity patients. Individuals in true crisis continue to be sent to the ED in order to have an access point to inpatient care. We know that our community crisis resources and our community behavioral health resources unfortunately have exclusionary criteria across our system and across our state, where individuals who are actively suicidal, actively homicidal, are actively using substances, or are aggressive in any way, are unable to be managed safely in these community programs much of the time, not all of the time, but much of the time. And so the emergency room becomes the de facto crisis diversion program. We know that with the changes that are rolling out related to 988s and some of the SAMHSA initiatives in Pennsylvania, work is being done to bolster mobile crisis programs. We know work is being done to build and expand upon crisis diversion programs. Still much work to be done in those areas. So at least for the moment, the emergency room still becomes the de facto place where much of this emergency psychiatric care is initiated. We know that in the emergency room, we are seeing an increase of patients who are presenting with behavioral health issues. We know that now across the country, 1 in every 7 patients going to an emergency room are presenting with a behavioral health issue. We know that this is often the initiation spot of care due to current problems accessing behavioral health quickly in other locations, and that care that is done well and safely engages both behavioral health staff and emergency room staff to begin treatment quickly and to quickly identify risk factors so that we bring the right resources to the right patient at the right time. We know that EMTALA laws designate psychiatric emergencies as equivalent to other physical health emergencies. Emergency rooms in our area have identified that as the numbers increase, it's unlikely we're going to see the numbers decrease quickly. Therefore, we are building capacities in those emergency rooms to be able to treat the behavioral health emergency in the same line as the other physical emergencies that present. Emergency rooms across the state are seeing an 11 to 15% increase in some locations. Other locations are seeing numbers closer to 50 to 60% increases per year based on the community-based resources that are available. We know that this has been happening for the last decade, but in many locations, the increase in utilization has accelerated pretty dramatically since our COVID epidemic has had effects upon our community resources. Working with think tanks across our service line and industry, we know that community use of EDs as an entry point to behavioral health has increased. We believe this is due to limited access in community resources. We believe this is due to an increase in the aggressive presentation of some patients. And we believe this is due to some of the other safety nets in the social determinant world not being as strong as they once were. Many times this is due to staffing and limitations that those staffing shortages are causing for community providers to be able to intervene early or catch individuals before they reach later levels of crisis. The work we're going to talk about today follow Dr. Zeller's 6 goals for emergency psychiatric care. These are in line with his empath model, and he's given multiple presentations across the state, which we have found valuable and formulary in the work we're doing in the emergency room. In these 6 goals, we're going to work quickly to be able to exclude medical reasons for the symptoms. We're going to work to rapidly stabilize acute crisis patients, making sure that we are avoiding coercion and treating the patient with respect and respecting their liberties. We're going to work to treat the patient in the least restrictive setting to make sure that they receive the right care at the right place at the right time, all while forming therapeutic alliances. We know that the cultures of emergency rooms and behavioral health units are somewhat different. We know that in behavioral health units, care is often done slowly and relationships are built through that care. We know in emergency rooms, we are treating symptoms quickly in order to stabilize emergencies, and therefore speed is sometimes prioritized over relationships. While that makes sense with many patient classifications with the behavioral health patient, we know that that causes escalations and at times can result in increased safety risks. The last goal we are addressing is in that setting, making sure that we formulate appropriate dispositions and aftercare planning. That aftercare planning might be inpatient hospitalization, but many times once the time is given to be able to de-escalate the immediate crisis, the underlying cause is better treated in day programs, outpatient treatment, or community-based care. We believe that our work being done in the emergency room is an important piece of the overall solution. We do not believe and will not purport that it is the only solution. In order to help address the underlying causes of patients coming to the emergency room in crisis, we need to help patients receive care quicker. And that means that in addition to building the resources in the emergency room, we're also looking to build resources in the community. Looking at some of the SAMHSA toolkits, the model we're looking at WellSpan is to make sure that we have urgent care outpatient access available or access points to care for patients not in crisis quickly. We know that at times behavioral health patients can wait up to a month for therapy, can wait up to 6 months or more to get a psychiatrist appointment based on insurance. That often is not quick enough to help the patient deal with the initial stress they are undergoing. That lack of access leads to increased symptomology, increased crisis, and increased patient safety concerns. So working to increase outpatient access, both in terms of availability and timeliness, is important. We know that our 988 work being done across the state and some of the SAMHSA suggestions there look at expanding our crisis programming, including both our mobile crisis, our telephone crisis, and our diversionary programs to help patients receive the care they need before it escalates to the point that there is an immediate risk to harm itself or others. So continuing to work with our crisis programs to strengthen them is also an important piece of this puzzle. That also includes working with our social service supports, making sure that we can address the social determinants of health needs that are necessary. So building, forming, and strengthening relationships with housing partners, food partners, aging departments, children and youth departments, making sure that the community is strong to help individuals manage when they are overwhelmed. We'll talk about our ED interventions here shortly and the importance of having behavioral health supports in the emergency rooms to help address and mitigate safety concerns. And then we know the downstream path of the empath models, treatment diversion programs, strong inpatient programs, and strong community treatment programs play a role in there as well. I'm going to pass off at this point to Adam Miller, our Director of Access and Crisis. He is going to review those interventions that we have put into place in the emergency rooms. We'll talk about the behavioral health resources that we have brought to the emergency room table as a way to make those initial interventions into improving safety. Once Adam is done, he will hand off to Billy Fisher, who will go into some of the protocols and standard work we're using to make that work. And then finally, we'll hand off to Dr. Garg, who will talk about the very important role that the psychiatrist plays in managing those emergencies and addressing safety before there is an outburst. Adam, if you are ready, we'll hand off to you at this point.
Thank you, Dr. Brickley. I wanted to pick up and talk just a little bit about what has been done to this point. Some of the work that we've started to complete is the introduction of master level therapists into our emergency department. It's a job title, we call it a BHC, or Behavioral Health Consultant. That's a specific job description, and we've had specific training for those staff as well. We've started to standardize workflows and standard works related to our evaluation and in-place treatment. Billy will talk a little bit more about this. We call it our phase plan. We've standardized trainings for patient sitters throughout our system. Again, that's a updated job description and specific training really focused on behavioral health intervention, de-escalation techniques, and that sort of thing. We've strengthened our consult services across the last 2+ years by adding APPs and CRNPs to complete some of our psychiatric consult work. That expansion has greatly aided in the number of consults, as well as decrease the time frame that patients are waiting for those consults to occur in the emergency departments. We've expanded community programs to help with diversion of patients. That includes mobile crisis, our START program in York County, and our ACT programs across our system. As mentioned, we've utilized the LDMS, or Lean Daily Management System process, to start daily bed huddles and surge huddles, which act to improve system planning and communication. Our huddles, as I'll talk shortly, these daily bed huddles occur once in the morning at 8 a.m. and then again at 4:30 p.m. I'll talk a little bit more about that in a moment. We've also worked hard to improve our data collection and predictive analytics. Specifically, we're looking at the length of stay of behavioral health patients, the number and time frame of psychiatric consults, the time frame of transportation. We've looked back over 2+ years worth of data to help project the number of patients in the EDs, to help with our staffing and placement of staffing as we look to decrease in the number of behavioral health patients in the EDs and their length of stay. Some of the next steps in our short-term plan is to continue to hardwire our bed surge meeting and improve planning and communication. That meeting is, the bed surge meeting is run by our behavioral health clinician. It involves behavioral health staff. It involves crisis intervention, as well as emergency department staff, to help improve the sitter planning, as well as patient flow and increase communication regarding placement and sitter needs within our system. We work to strengthen sitter resources by streamlining training and increasing the sitter pool, as I mentioned. Again, that is a system initiative. As mentioned, we've added master level therapists in our EDs to manage the increase in patients. We continue to look at where we can increase the need. How do we do that per shift? How do we move our staff around throughout our system where the need is? Sometimes the need is in one particular emergency department versus another, and so we will try to move staff accordingly. And also, as mentioned earlier, shifting the crisis staffing to support our community treatment. Part of that is in support of the 988 legislation and services that have been initiated, but also looking at growth within our programs, within mobile crisis, as also responding to some recent RFPs for services. Midterm, we are starting to look at the increased use of telepsychiatry. We recently welcomed a psychiatrist, Dr. Patel, to that team. The use of telepsychiatry greatly reduces the wait time for consult services throughout our EDs, and because they're not placed in one particular emergency department, the ease of access for patients is greatly increased as they can oversee services and consultation services in several EDs that same day without having to do the travel, of course. We're continuing to look at hospital consultation services redesign. As mentioned, that's utilizing telehealth services, APPs, CRNPs, physician assistants to grow and connect our service line versus just using psychiatry services. We continue to look at the expansion of ED diversion. As Dr. Brickley mentioned, if we can continue to work in the community and keep behavioral health patients appropriately out of the emergency department and appropriately in community services, that would be a win. We're utilizing our START program, walk-in crisis intervention. We continue to look at how our community crisis walk-in hours are protected. How do we carve those out and ensure that there's an expansion of hours as well, including weekend hours? We look at creative ways to utilize our outpatient resources, including a transitional care team or TCT team, which utilizes short-term therapy, short-term medication management services as a way for ED diversion, quick services, and then connecting back to their current provider or connecting to a new provider as needed or as the situation deems necessary. And of course, we're looking, as mentioned, expanding our virtual care, whether it's our shared care model and telehealth services. Shared care model is a collaboration between our primary care physician offices and behavioral health, where we've embedded behavioral health staff, again, as a way to increase services and utilization of behavioral health care within the community. Long-term care plans look at continuing to enhance the different models that we've started to use. That includes the empath model, building upon crisis diversionary programs, ambulatory services, and looking into behavioral health emergency room payment models and options. We are starting to collect a lot of data and information in terms of the number of services, things like therapy, individual, family therapy services that we're offering, consultations that expand outside of psychiatry, which include behavioral health, ABA type consultations, and autism and ASD, IDD consultations from trained staff in those specific areas. Also, within our system, we are looking to expand beds. Of course, the expansion of beds within our system would help with the patient flow of behavioral health patients. And so the more beds you have, of course, the more patients you can accommodate within an inpatient setting. Part of the lean daily management system are these tiered huddles. The tiered huddle that we utilize for our bed huddle process. I know this is not readable on the screen here, but this is the standard work for our bed huddle. What we're trying to accomplish with this process is to bring together all of our emergency departments, our behavioral health staff in those departments, crisis intervention, our behavioral health unit leaders, and our administrative leaders to come together each morning, 7 days a week, to discuss patients in our emergency departments who either have longer length of stays, disposition concerns, current acute behavioral concerns in the emergency department. That is one, either disrupting services in the emergency department or staffing, certainly staffing and staff safety is an issue there. And then also for disposition, as patients are more acute in the emergency departments, of course, they're a little bit harder to find beds for at times. So we start to discuss the process, what interventions we need to use, who's doing the psych consult, just expanding on the psych consult in terms of what other consultations we need. I mentioned ABA, IDD consults. If a therapy or family therapy consult would be appropriate, starting to coordinate those services. We look at, again, bridging that all together, looking at barriers around things like transportation. How can we accommodate the open bed at a specific facility and get transportation set up? And if we can't set it up, how do we troubleshoot that? And what are our strategies and opportunities to move patients quicker through our system? That's a daily task that we're doing to continue to learn how to best do that. One of the most pieces of the bed huddle that I think is most important is that it increases the communication within our team. Working as a system, when you're talking about 5 different emergency departments, 4 different behavioral health units, crisis intervention out in the community, crisis intervention services that fall under the WellSpan umbrella, crisis intervention services that fall outside of the WellSpan umbrella. How do we continue to communicate effectively and really triage the patients that need to be moved the fastest? How do we identify patients who have medical complexity needs that might need a medical bed? COVID is a great example of that kind of complexity. And how do we communicate that effectively? And this huddle twice a day has been a tool that has greatly impacted our communication and patient flow. I will now turn it over to Billy, who again will talk a little bit more about some specifics within our phase plan, as well as a specific example.
Thanks. Thanks, Adam. So I'm going to talk a bit about what we call the phase plan. Before I do, I want to start by sharing a brief patient story. Patient identifiers have, of course, been changed to protect patient confidentiality. Sarah was a 14-year-old female who was a well-known consumer to one of our system emergency departments. She presented to the ED with self-harm, suicidal ideations, and homicidal statements. She had minimal support in the community and a very sad home life. Sarah had 4 previous visits, each one with a long length of stay, with the longest length of stay being just over 15 days. Behavioral health coordinators in the emergency department had attempted to find an appropriate inpatient bed on each stay, but to no avail, primarily due to her behaviors in the ED. These behaviors included elopement attempts, strangulation, and self-harm, and physical aggression, which unfortunately resulted in staff injury on a few occasions. So the phase plan is what we're looking at here on the screen. The phase plan was hardwired for use by the behavioral health coordinators with a primary purpose of improving safety and expediting care of the patient. The phase plan outlines interventions used by the BHC at specific patient length of stay intervals. And so phase 1, at hour 0, the BHC completes a safety screener, which includes an in-house safety plan. Self-soothing resources are provided to the patient. This may include mindfulness exercises as well as breathing scripts. The BHC also gives observation recommendations for patients entering the ED to nursing staff. So we know that no 2 patients with suicidal ideations are the same. An individual with a plan to end his life via stepping into traffic may present to the ED with insight and desire for treatment, while another individual may be unwillingly brought in by family and may attempt to harm themselves with a bed sheet while they're in the ED. While every behavioral health patient has some observation level in the emergency department, some require more stringent observation. The BHCs assist nursing staff in this phase by doing a safety assessment for initial observation status. The BHC will continue to do this every shift because we know that patient status is dynamic. So additionally, in phase 1, really the goal is disposition planning. A patient presents to the ED. We're doing a mental health evaluation, and we're doing a bed search, or we're coordinating for safe discharge. While they're waiting, though, we're giving safety recommendations to the ED, and we're also assessing for indicators that might make an inpatient bed search more difficult. Phase 2 really is when we start our psychiatric consults. We're moving to start treatment via medication stabilization, and Dr. Garg will talk about this a few slides later. I'll give her some space to do that. We also, at this point, as Adam mentioned earlier, will reach out to our specialty consult teams. CAD, for example, our Center for Autism and Developmental Disabilities, will complete consults for any patient that has an established autism spectrum disorder diagnosis or an intellectual disability. And really the purpose is to not only provide diagnostic clarity while we're in the ED, but assist with behavior planning if there's a need for that, as well as to coordinate resources post DC from the emergency department. Phase 3, the BHC will start collaborating with the managed care company, asking for an expanded bed search if a bed search has proven to be problematic. We'll also inquire about an enhanced rate for that same reason. Utilizing all of the above strategies in phase 3, so at every phase we're continuing a bed search. We're also looking at diversion. We sometimes affectionately, call this, we're burning the candle at both ends. So while we're actively searching for an appropriate inpatient bed, we're also at the same time preparing the patient for discharge by asking the question, what does safety in the community look like for this particular patient? Phase 4, we start moving into more structured interdisciplinary teams. And just a quick comment, Adam had mentioned the huddles. We're doing that daily, and we're having daily coordination. But in phase 4, we have a more focused internal review for that patient, reviewing the specific barriers that are holding up placement. So an example may be if we have a patient who in one of our emergency departments that is more medically complex, they may be more appropriate for one of our medically based BHUs rather than Philhaven, which is a freestanding psychiatric facility. We'll have those discussions internally with our inpatient teams. If a patient has outpatient resources, we will establish a regular cadence for review and collaboration via meeting and treatment planning. In phase 5, so phase 5 is when a patient has been in the emergency department for 73 hours and up, we're continuing with all of the above interventions. Psychiatric consults are continuing to occur at minimum every 48 hours. Our site medical directors are also briefed on those patients, and they consult on cases. And just some notes about the phase plan. Throughout, the BHC is completing daily progress notes. They're also completing therapy consults when clinically appropriate. An example is the utilization of family sessions to determine that discharge home is a safe alternative rather than waiting for an inpatient bed to open up. Let's move to the next slide here. This is our process map. This is essentially the outline of patient flow through the emergency department. And I'll move through this slide rather quickly, but essentially wanted to just highlight a couple key points here. So this first row is where a patient would enter the emergency department, and the BHC would do all of those tasks mentioned in phase 1. So they're doing that initial safety screener, complete with the in-house safety plan while they're in the emergency department. They're assessing for any indicators that a red flag meeting may need to happen earlier. So we know if a patient presents with aggression or they're sexually acting out, that's a patient who may be more difficult to place. And so we'll start pulling in some of those later strategies in the phase plan and early based on that initial presentation. There's only 3 entry or exit points once a patient enters the ED, and those are highlighted by the circles. So the first one is a quick diversion. The BHC will assess a patient in that initial safety screener, and if this is a patient who's low risk and maybe they were sent to the ED by their PCP for medication refill, and they're having some anxiety. They just need some resources. We'll connect them with resources, complete a safety plan, and discharge them. If at any point a patient has been recommended to receive a higher level of care via inpatient treatment, the exit points are either going to be they're placed at a facility, or they're eventually discharged back to the community. And so the bottom section there where that orange block is, that's the indicator for our phase plan. And every time a patient enters a new threshold, the BHCs will start implementing different strategies as discussed in the previous slide. So going back to Sarah and her most recent stay in the emergency department. The most recent stay, the BHC was able to intervene at hour 0 and created a safety plan for her. They worked with nursing staff to make them aware of the plan and the course of action. We also had a consult occur with our ABA team to look more in depth at some of the behaviors that were occurring, and recommendations for reinforcing positive behavior and not reinforcing negative behavior were made. Additionally, psychiatry consult was ordered day 1, and recommendations were made not only for PRN medications, but also for ongoing treatment. And so treatment essentially began in the emergency department day 1, as opposed for the patient waiting for treatment to start once an inpatient bed had occurred. Additionally, there were interagency meetings that had occurred daily. Patient had been connected with family-based services as part of a discharge from a previous stay in the emergency department. And so this time we were able to collaborate with her new services through family-based and rehearse family dynamic conflict patterns while the patient was in the ED with mom. The BHC was also able to collaborate with family-based and work on a community safety plan. And so, yeah, the outcome is the patient received treatment, and most importantly, there were no safety issues throughout the duration of the most recent encounter in our emergency department. So I will now turn over to Dr. Garg to further discuss boarding patients in the emergency department.
Hi, good morning, everybody. Thank you, Billy. I'm here to talk a little bit about the patients that we have been seeing in the ED and what we can do as a consultant to make this whole process smooth. So to start with, I'd like to talk about what a boarding patient is. So how do we define a patient who's boarding in the emergency department? And a patient who remains in the emergency department after determination has been made whether the patient needs admission or needs to move out but continues to be in the ED would be considered a patient who's boarding. There are many theories that go behind seeing the increase in number of the boarding patients, including a shortage of inpatient beds, a shortage of the outpatient mental health resources. Also in 1960, there was a shift away from institutionalization of the mental health patient, which may also be contributing to what we are seeing now. We all know about COVID and how that has impacted things, and that's probably also causing an increase in the number of patients that we are seeing. So trying to understand what is it that we as the provider and them as a patient experience by being in the emergency department for longer periods of time. We all know our emergency departments are a place where patients have traditionally been stabilized and moved on to the next level of care. And if the patient is there for a longer period of time, they may not get the best care that they would probably get at a psychiatric facility. Due to some limited ED resources, not having enough skilled staff, and not being equipped with the appropriate resources, we may see an increase in morbidity and mortality of these patients. We may also see an increase in aggression, some unsafe behaviors, And these are all ways of the patients expressing a need to be seen and a need to get higher services. They may be at a risk for getting decreased quality of care. It may lead to a decreased satisfaction, both for patients and for the provider. We also struggle with some milieu management problems because we have a combination of patients over here. We may have a depressed patient with a patient who's psychotic, with another patient who's aggressive, and having all of them in the same environment can be very challenging. So what can we do about it? I think identifying a patient early on who's going to be there for a longer period of time is the key. So let's talk about some characteristics of boarding patients versus non-boarding patients. So non-boarding patients usually present with depression, suicidal ideation, or an unspecified mental health disorder. They are less severe, they are easier to manage, and they can be discharged with a safety plan. A lot of the patients who have a briefer stay in the emergency department have private insurances, they have better support system that helps us with the disposition. They are also more, they understand the system better and they know how to navigate the system. So they may make a decision of not going to the emergency department and might call their primary care doctor, or else we see a group of patients who may not even have a primary care doctor and they end up coming to the emergency department. Now, what are some of the common characteristics of patients who we see who stay in the emergency department for a longer period of time? We see children who are younger than 12 years of age. We all know that there are a few inpatient facilities that do not accept patients less than 13, which makes it harder for them to be placed. Male patients, patients who have government-funded insurance, any neurodevelopmental or neurocognitive disorders makes it even more harder to place them. And why is that? Because many a time they are not able to keep up with the expectation of the unit. It is harder to manage them on the inpatient facility, and they may not even have the resources to manage them. Any patient with aggression, multiple hospitalization, personality disorders, any juvenile involvement or CYS involvement makes it much harder to place them. So what can be done? Traditionally, we have always looked at the emergency department a place where we stabilize the patient and we move them forward to the next level of care. However, in the recent years, we have seen an increase in number of the patients being in the ED for a longer period of time. So while they are there, what is it that we could do? One of the things that we always have left to the next level of care is to clarify the diagnosis. While they are there in the ED, involving a psychiatrist and understanding their diagnosis really helps. If we can understand the diagnosis, we can understand what we can do for them while they're in the emergency department to make them comfortable and to plan a good disposition plan. Involving more specialists while they're in the hospital would also be helpful. So while they're there, we can have family-based services, as Billy mentioned, maybe CAD services. These are our autism services that we have at WellSpan, involving them. And of course, the psychiatric physician can be very helpful. Supporting all the teams that are involved, including our ED team, our crisis team, the medical team, the ED physicians can also help bring everybody together and work as one. Coming up with a plan early on in treating their presentation is always helpful. Just like Billy mentioned about Sarah, the last time that she was with us, we were able to come up with a plan early on, trying to work out with all the aggressive outbursts or any unsafe behaviors. PRN medications really helped us make that stay really smooth. Looking at detoxification of substances, if that is an issue they come with. Trying to work on any resources we can provide them upon discharge that will prevent them from coming back to us. Again, as we've talked about this a little, but addressing the behaviors that we are seeing while in the ED can be helpful. So as a physician, maybe talking about PRN medications while they're there to decrease the aggression, trying to medicate them ahead of time so we don't see that aggressive outburst and everybody, including the patient and the staff, continue being safe. Impulsivity and hyperactivity has always been an outpatient diagnosis. We've always waited for the outpatient doctor to take care of that. But at this point of time, I think it would be helpful that we start treating the patient while they are in the emergency department. Sleep, appetite are two important things. If we can stabilize that, we can really take care of their moods and aggression while they're there. So to summarize, taking care of any medication interventions, any emergency medications, PRNs versus scheduled, would really help. Again, this talks about Sarah and how we had planned all of this in her last stay, which helped her having a very smooth stay with us. Talking about a change in mindset, I cannot emphasize enough, we've always looked at the ED to stabilize the patient and move on. We usually don't try to start any new medications while they're there because we don't know what the next accepting physician might want to do with their medication. But I think we may want to move away from that mindset and start treatment while the patient is there. It helps not only the patient, it helps the staff, and it helps everybody work together and make that stay smooth. To summarize, early identification of potential boarding patients is helpful. Coming up with targeted case management, so including everybody that can be helpful, including any outpatient services, any inpatient services, and talking about any services that we can provide while the patient is in the ED can be helpful. Making multi-system referrals and starting more intensive patient treatment while the patient is in the ED can be helpful. I think this is a new way to look at things just because of the numbers and the volume that we are seeing in the emergency department. Having said that, I think we at WellSpan have really worked hard to come with a very strong team in our emergency department, try to develop standard workflow across all the hospitals that we cover and improve our communication, which has really been helpful. Having done all of this, we also have to look at other levels of care and improvements that we can bring in the other levels of care to decrease the backlog that we are seeing in the emergency department. And by saying that, I mean increasing our beds in the inpatient facility, making more services available in the outpatient to prevent patients actually coming to the ED. With that thought, I will hand this over to Dr. Brickley.
Okay, so to summarize, our goal is to make patients and staff safer. To do that, we have implemented some behavioral health additional resources into the emergency room. We've done that so that we can have early identification of those patients who are going to be potential boarders who are likely to get stuck because of either bed backlogs or their presentation is such that inpatient units or community-based units aren't able to accept them quickly. As soon as we identify them, we're looking to initiate targeted case management so that we can increase, improve, and speed up our coordination with outpatient agencies, community providers, as well as our friends in the county at our MHMRs, MHIDDs, BHIDSs, our children and youth services. As a group, we make multi-system referrals quickly, looking at the right level of care and not necessarily waiting for the inpatient team to make those recommendations. We start to provide more intensive patient treatment to foster stabilization quicker. We begin medications sooner when appropriate. We begin therapy sooner when appropriate, hoping that we'll be able to gain some of that stabilization and some of that improvement that makes placement possible quicker. Our goal is really to have a new day in behavioral health urgent crisis care that allows us to stabilize and begin treatment when we encounter the patient, not necessarily hold the patient. Our goal is to decrease stigma and to help our patients receive the care they need sooner so that they are not left with behavioral outbursts due to frustration or being overwhelmed or being in a situation they cannot manage. I think that will be our presentation. Kelly, would you like to lead us through our questions and answers?
Thank you. And thank you to all of you for this presentation. There was a lot of great information. That concludes the slide presentation portion of our program. Now we'll begin the question and answer period. So a couple of questions are coming in. Are you doing 100% screening for suicide or self-harm, or doing it only for those who present with signs and symptoms that your BHC then sees as an assessment?
We are doing 100% screening. When we identify a risk or we have a heads up, we do a more in-depth screening, but we're looking to make sure that everybody is safe.
Thank you. And I have another question here. Can you explain what the START program is?
Definitely. So the START program is an acronym. It is, see if I can remember exactly what it stands for. It's our specialized treatment and referral team. It is a combination of a urgent behavioral health crisis program with a certified behavioral health center or clinic. It is looking to provide quick assessment, quick care, and then transfer individuals out into the community when appropriate, or send them to the inpatient ED if necessary for inpatient clearance, medical clearance. It pulls together our crisis team with our psychiatry team, with our physical health team, to provide just-in-time care for the most important issue that is causing a patient stress.
Can you provide a little detail how that team gets activated?
Sure things. So when crisis intervention is pulled into a case, the old way of doing it would be for crisis to do a phone evaluation and then send a patient to the emergency room if we thought there was a safety concern. The new way of doing it, crisis intervention may do a telephone screen, or preferably they'll go on site and meet with the patient. They'll do a more in-depth evaluation, more in-depth risk assessment, and if the patient is needing inpatient hospitalization, there's an immediate risk for safety that needs that level of care, then we'll facilitate transport to an emergency room. Many times we find that the individual, if they receive an outpatient therapy appointment or an outpatient urgent psychiatry appointment that can happen today, maybe tomorrow, that individual is able to get their needs assessed now, as opposed to needing to go to inpatient. So for those patients that might go to the emergency room and get an appointment quicker on outpatient because they were in an emergency room, we're kind of bypassing that step.
Thank you very much. Can you provide clarification on your training for sitters or type of the staff that you use for the sitter role?
Billy, would you like to take that one?
Sure, I can speak to at least a piece of that. So our sitters or patient safety aides are all given a specialized training. It's the high risk observer training. And so that's what those staff use. Dale, I don't know if you have any other comments on additional, like ongoing training or anything like that.
Yes, so our high risk observer training is similar to the first couple of days of training that we might give to a psych tech working on a behavioral health unit. We do it in levels, knowing that resources are always at a premium and staffing is always hard to come by. So we'll have our patient safety aides or our sitters put into a couple levels. The first level, their job is to really observe the patient. They're receiving 4 to 8 hours of trauma-informed care training, behavioral de-escalation training, documentation training. They're learning how to identify the warning signs and pull in the right supports. We have a higher level patient safety aide. We call them patient safety aide 3. Their job is to be a little more interactive with the patient, to provide a little more support. They're participating in a 24-hour class. In that 24-hour class, they are practicing the de-escalation. They are learning triggers. They're learning to identify weapons. They are learning to do basic interventions, much of which is then when to pull in the right individual, which is often our master's level staff. We know that this is time, a very big time commitment. It is not easy to find the time to free up these individuals to fill this role. Despite that, we know that when we don't give the time to these individuals, we're putting people into a position that they're not ready for. They're scared of the patients. That often leads to poor outcomes, increased violence. So we found it to be a very good use of resources to make ourselves find the resource for our staff to get that training. And then we can go into much more detail on that at a later time if anybody wants to reach out to us.
Well, Dale, actually, in that same vein, because I thought it was interesting, you had said during the presentation and talking about de-escalation. So that's that higher level or that tier 3 individual as opposed to maybe the tier 1. Is that right?
That's right. It's really how do we institute trauma-informed care? If we can help our staff, and we do help our staff, know how to speak to the individual in such a way that we're asking what happened to the individual as opposed to what's wrong with the individual, that goes far for both the patient's experience as well as the staff's experience.
So there is an additional question that what is your opinion about using security personnel to do high-risk patient monitoring? Can they be a level 1?
Well, we put all of our security team through level 3, to be honest. We believe that that is a very important investment in their development. The culture of security is to protect. Oftentimes, our security team will protect by using physical interventions to control a situation. That sometimes has good outcomes, many times does not. So by making sure we have all of our security trained to that level 3 or the 24 hours, we're really helping our security team identify how they can manage a situation and keep others safe by sometimes not physically intervening, sometimes taking a step back and quieting the room as opposed to having a show of force and bringing too many people into the room. Really helping them understand the difference between a person is making a decision to act out or a person is reacting to negative things they're experiencing. So our security is definitely part of this, but we invest the time, we invest the training to make sure that they have the tools to do this well.
And I think, like you indicated, it's a lot of time and resources and trying to accommodate all of that information. It's definitely a commitment, which I'm sure your leadership is definitely supportive of.
Yes, we have a great leadership team that wants us to get out in front of this. When we've done some of that analysis and when we look at the costs and we're working on getting reimbursed for these services, downside of not doing this upfront investment is the amount of time, the amount of cleanup, the amount of engagement problems you have to address, both from patients and staff, if you don't do the upfront work. So it is a lot, but the benefits on the back end, we have seen significant improvements. We've seen hundreds of thousands of dollars of reductions in employee injury claims. We have seen patients move through the ED quicker, therefore reducing the loss that most EDs experience on having behavioral health patients take up valuable beds. We've been able to reduce the number of staff who respond to an event with better outcomes. So still work to do. We're still learning as well. And would love to hear from others who are on a similar journey on what they're doing and what their successes and challenges have been. But we really are focusing on getting ahead of the issue so that we can proactively meet needs as opposed to reactively address safety concerns.
Well, we appreciate your input and thank you to all our presenters for this presentation. I do want to be conscientious of our time because we are at 12:02, but I would like to close with a comment from Debbie, who was one of the participants, who said, "Thank you for sharing this project and interventions. Typically, the psychiatric patient is warehoused for days until a bed is found without therapy and any interventions. This typically causes escalation in our patient's behavior. The worst place on earth for these patients is in the hallway of a level 1 trauma center ED." So I'm going to close with that. Thank you so much for this valuable presentation. I want to thank everyone again for joining us today. This concludes our webinar. Thank you.